All right, why don't we get started here? I want to try to keep on time here, give our speakers enough time to get through their presentations. So just at the start here, we're talking about surgical treatments. I just want to say a couple quick words about these presentations. The purpose of this session is to provide a little bit more of a broad overview into surgical treatments and surgical options for nystagmus. We have two surgeons that are going to speak to you today who are looking to try to improve the type of surgical treatments that are available. And they're taking very different approaches to do this. And so we wanted to be able to show you emphasize that what they're working on are experimental treatments. They're looking to try to improve the treatments. So these are very much works in progress. This is the cutting edge of treatment options. And I want to stress that we want to be clear that there's no one right surgery for everybody because everybody's a little bit different. Every person's nystagmus is a little bit unique. And so having one surgery for everybody is really not possible. In fact, surgery may not be the right option for you. So what we want to try to do with this presentation is give you some perspectives on some different surgical treatment options so you can make an informed decision that what might be the best treatment option for you. So the two speakers we have, you may have seen last night, is Dr. Dongsheng Yang and Dr. Robert Lingua. We'll start with Dr. Lingua. Trying to find his bio. Here we go. So Dr. Lingua is a clinical professor and director of pediatric ophthalmology and strabismus at the University of California, Irvine. His clinical research involves innovative surgery to improve nystagmus in young children to optimize their vision development and in adults to improve their quality of life. He's creating the first eye institute for children with special needs, the Gavin Herbert Eye Institute. He's a graduate from the University of Southern California School of Medicine and received in ophthalmology and received his ophthalmology training at the College of Medicine of New Jersey. He returned to USC for a fellowship in pediatric ophthalmology at the Children's Hospital in Los Angeles. So please welcome Dr. Lingua.
Thank you very much, Joe. And you're absolutely right, just to continue your comment, and hopefully you'll come to understand that we really are is at the beginning of our surgical research, because in order for us to really be able to conscientiously and appropriately apply surgery to a patient, we really need to feel that for that patient with that kind of eyeball, with that kind of nystagmus, with that kind of nervous system, that they have a more than even chance of experiencing some improvement. So certainly it's way early in our research in nystagmus to suggest that any one procedure is going to be appropriate because you're not all the same. We're also getting better at trying to understand the aspects of operating in the world visually that are way beyond reading a vision chart, way beyond just quantitating the amount of movement. And so that's really one of my goals today is to get into that part of research. I'd like to thank all my friends and prior patients who are here at their own expense, coming long ways. I understand this is being streamed. I can't identify you. It might be a HIPAA violation, but feel free to identify yourselves as you wish later on in the question and answer. So what this brilliant young child is telling us with this face turn is that, can we close the back door, please? With this face turn is that if they move their head into a position where the eye movement is less, they're happier with their quality of vision. Pretty simple. And so basically that's what a lot of our surgery has been directed towards since we've been doing this research, is trying to find out to what extent and how much do you actually improve someone's vision with their kind of nystagmus if you minimize that shaking like you do if you create a null point in all positions of gaze. So we'll get into this a little more later, but we're understanding a little more, and I was so glad to hear it discussed at our research conferences, that assessing strabismus, assessing muscle surgery as a successful therapeutic intervention really has so much more to do with how you read a vision chart. And we even heard it last night at the Q&A. We're talking about trying to go up and down stairs. I want you to, by the end of this conference, really come away with an idea that when we're looking at acuity in terms of trying to optimize your ability to move in the world, we're looking at something beyond reading a chart acuity. We're looking at something called dynamic visual acuity, And that's something that I hope I can explain more thoroughly for you. I have to make sure I get through this so I don't take any of Dr. Yang's time. I'll be on time here. This is a patient with nystagmus, and he was operated back about 2001 by Dr. Sinsky, and you can see in the center picture his nystagmus in primary position was quieted, and even 10 years out, it hadn't come back. Now, I got to see this video of this 10-year follow-up of this patient while I was taking care of another patient who I'd already operated with traditional thinking surgery. He already had tenotomy reattachment and 4 muscle large recessions. Can we eliminate the volume of that, or is that my end? Okay, we're just asking him to look. So suffice it to say, the nystagmus that he was left with was still insufficient compared to his clinical goals. Should I pause that?
Yeah, pause for 1 second. I have to back out. I just have to back out for 1 second. I have to back out.
We need to mute that. So after his primary procedure, as a 17-year-old still looking to get a driver's license, he was unhappy with his outcome. I was frustrated, as I've been over the last 30 years with nystagmus surgery, never really ever being able to get to a point where I was able to, have a patient feel that they were achieving the outcomes that they had in their own mind when they went for the surgery.
I'm sorry. That was written. I'm sorry. Just want to get back. Can I go back to your PowerPoint then?
Okay.
Yeah, I'll open it.
Thank you very much. So with Dr. Sinsky's help, he was the first patient that we performed a myectomy or muscle removal procedure for. And this next video, as soon as that loads, will show you his improved alignment almost 4 years post-op. It takes a minute to remember this. So what we learned from that procedure was that in his condition, which was an idiopathic infantile nystagmus, perfectly normal eyes, normal visual potential, if we were able to reduce the shaking of his nystagmus, we were able to improve his operational acuity. Stand near the mic? Okay, great. So, and here he is now 4 months out with a little bit of a face turn, but you see his eyes are quiet. And much to our surprise, even after performing a muscle removal, I really want to be sure also by the end of this conference you get away from the myth that if you disinsert a muscle from the eye won't move. So please, if that's still anywhere in your thinking, eliminate it completely. We can go a little further to make those movements more perfect, which is part of our research, but that they can move within a clinical amount so that you can operate in the world is something that can be accomplished after muscle removal. And it was pretty dramatic for some patients. This is a patient who had already had 3 procedures and was thinking she'd have to be that way her whole life. And here she is now about 3 months post-op after myectomy procedure. So these were part of the early extirpation surgeries, which we have abandoned after we did the first 10 or so because it required us to go back into the posterior part of the orbit to remove muscle, which exposed the patient to a risk of hemorrhage. So we wanted to see if we couldn't take less muscle and achieve the same type of surgical results. So our first presentation was in 2016 on a kinder, gentler version, which was taking the more anterior portion of the muscle and removing it with the idea that if we just snipped and removed it, it could not reattach to the eye. How does the eye continue to rotate? Well, because the muscle is still functioning. The muscle is still innervated. The muscle attaches to other tissues around the eye that join all the muscles together so that as that muscle contracts when you're trying to look in a direction, there's an indirect shifting of orbital contents and movement of the eye. And we see that in patients even after they have a removal of an eye. Say for cancer, a lot of the tissues around the eye continue to move well. So here's another patient who had a significant nystagmus after strabismus surgery. And we performed the anterior myectomy for her, And what it gave her was the opportunity to look at someone straight ahead with a quiet null point. But you see she has an underaction of that inner muscle. I'll see if I can pause it. And so the main portion of our research now is geared toward not trying to get the nystagmus to stop, but getting it to stop as well as retain normal eye movements. I'll move on from there. So this is an MRI, and it's from Dr. Diemer's work on pulleys and connections between the eye, the intermuscular septum, and the orbit. And what we see is when the eye is in an outward position, this attachment of the muscle to what's been called the pulley, or the intermuscular septum that unites all the muscles in a skirt around the eye, does have a posterior shift when that eye now turns in toward the nose. In fact, he was able to even show that that happens in the absence of a globe after it was removed for cancer. So if you detach the muscle from the eye, the muscle can still be attached to the pulley, and it can still retract into the posterior orbit. So our main last series of patients we looked at after myectomy was looking to see if we joined that muscle to the pulley in a predictable, definable way, would we get sufficient increased ocular rotation. In addition to doing that, we also did some additional tests, which, thanks to that group, taught us to really look at surgical outcomes in a different way. There were 5 patients with foveal hypoplasia and 5 patients without, so it allowed us to get some pilot data on different types of patients with nystagmus. And we put them through a whole battery of tests, but perhaps the most important to talk about today is static acuity, that is when you're trying to look at a static chart, a chart that's not moving, and dynamic visual acuity. That's the acuity that results from eye motion. We also employed the quality of life questionnaire from our colleagues in the UK that is nystagmus specific, and it's a 29-point questionnaire that asks the patient to evaluate how they feel about certain parts of their life with nystagmus. So first of all, let me say that in terms of visual acuity, just from the quieting procedure, both patients on average, with or without a fovea, experienced some improvement in their static acuity, to read the chart. Foveation time you've heard quite a bit about, and when we calculated that, despite very large increases in foveation time for the patients who had foveal hypoplasia, we didn't see corresponding huge increases in their acuity. And again, this gets back to the fact that seeing, moving, working within the world has a lot more to do with foveation time, especially in the patient who has some retinal underdevelopment. So this quality of life questionnaire asks people to state how they feel about a particular aspect of nystagmus, and important to us was question number 27, which says, nystagmus blurs my vision. And they would score it anywhere from very much so to not at all, from 0 to 100. So with 29 questions, if a patient scored 2,900, it meant nystagmus doesn't bother my vision at all. So I've colored in these charts because it's just too much information. So I just want to draw your attention to the colored columns, which basically split the questionnaire into the first 17, which have to do with your personal and social issues with nystagmus, and the last 12, physical, environmental, including how does nystagmus blur my vision. And on average, both groups, with and without foveal hypoplasia, all 10 experience an improvement in their quality of life. So they're all having an improved quality of life. They're all feeling like nystagmus blurs my vision less. So what is it that we're measuring? What is it that we're doing to the patient that we're not measuring that is making them feel more comfortable about their nystagmus? And that takes us to the idea of dynamic visual acuity. Now, dynamic visual acuity is a real thing. It's the log linear relationship between motion and your ability to perceive. Okay, so saying that real simply, it's the vision that you're capable of when either the target's moving or you're moving. Well, isn't that nystagmus? you're moving and the targets are moving, especially if you're driving, walking, stairs, whatever. So it's a measure of the impact of movement on your vision. So how do you determine that for the nystagmus patient? Well, it's a direct function of the velocity of your nystagmus. And the velocity of your nystagmus we can measure on the nystagmographs. So every one of us have a different nystagmus with a different velocity, and the higher that velocity, the worse your dynamic acuity. So perhaps a lot of what we're doing with ablative surgery for the eye muscles, reducing their function as much as possible in terms of the shaking, is reducing that velocity. We're doing more to reduce velocity, which reduces and improves that dynamic visual acuity, rather than having you see another line on the chart, because a patient can have a huge improvement in their quality of life, yet their improvement on the vision chart might be one line. They might have no nystagmus, or they might still have a little shaking. But those two factors don't really correlate with how much they think nystagmus blurs their vision and how they operate within the world. This was borne out in a nice straight line relationship in the preoperative evaluation of our 10 patients, which is showing that the more the eyes shake, the worse the dynamic acuity, the more likely they were to say, nystagmus blurs my vision quite a lot. And the lower the velocity for that patient, even pre-op, the more likely they were to say the nystagmus blurs it kind of moderately. Okay? So there is a direct relation, even in unoperated patients, between how much and how fast their eye moves and how well they feel about the quality of their vision. So I think we're evolving more toward being able to answer that question for patients who say, is nystagmus surgery good for me? Well, 8 of the 9 subjects had a reduced velocity from myectomy, and they all experienced an improvement in their dynamic acuity and reported at least a 50% improvement in their nystagmus-related blur from the questionnaire. So asking a patient before you make a decision on surgery what their dynamic acuity is. So you have to have a nystagmograph to see what the velocity is. You have to compare how you think that velocity is affecting vision to the development of the eye, such that if you change the velocity, is the patient going to be able to appreciate an improvement in their vision? That then makes them a good candidate. Okay? So if a patient has low eye development and they're not capable of appreciating changes in velocity, chances are pretty good they're not going to see a real change in their quality of life in terms of vision. They may like it from a cosmetic perspective, but in terms of, am I going to see and move better in the world? So if this relationship is maintained in future studies, it's reasonable to suggest that with this data, that dynamic visual acuity, compared to what we call the static acuity, or looking at a chart, we're going to be able to tell the patient more about what they have to gain in terms of moving through the world. Okay? And I think that's going to be an important part of what we recommend all surgeons do in their future studies. It's not going to be sufficient anymore to say, look at the person, oh look, they shake, they don't shake, whatever. Okay, that's one thing. That's more of a psychosocial issue. How much the patient hoped to gain from not having the appearance of nystagmus. That's one factor in considering surgical candidacy. But we're also going to be able to say, based on your velocity and your eye development, this is your chance for experiencing a better sense of vision moving within the world. While you're moving in a car and signs are moving by you, when you're skiing and the posts are flying by, how am I going to be able to achieve that? Now, again, this is a very busy chart, but basically I'm just going to direct you over to this green column, which shows the delta change, the amount of reduction in dynamic, in velocity that we can achieve for patients, which ranges anywhere from 36 to 97% with myectomy. So we can really quiet that velocity, and of course that then translates to the percent improvement the patient experiences in their appreciation for nystagmus blur. So in my last couple of minutes, let's just go through a few of these tracings. This is a patient with esotropia and nystagmus, and now post-op 6 months. You can see that the esotropia has been improved, and their ability to control their eyes in the primary position is significantly improved, almost flatlining their nystagmus. This is him now clinically, and he is a 22-year-old in school to become an airline mechanic, and so I think I've done something socially to help make sure that he's able to see those rivets and such. And he has very good ocular movement preoperatively in spite of his esotropia, and now postoperatively at 6 months. He's able to hold his eyes quiet in the primary position, but even after myectomy, I think you'll see that his horizontal rotations are perfectly adequate. How can that be? Well, that's even something we need to understand even better with some higher resolution MRI studies to actually see where that muscle is attaching. What's even, excuse me, here's just another example of a quiet result, pre-op on the left and post-op on the right with good rotation. I'm running a little bit out of time, so I just want to be able to show this interesting patient who not only has quieting of their nystagmus in the primary position, but this is patient number 3 that we've talked about before. But his primary complaint was that people kept bugging him because every time he looked to the side, people would say, hey, why are your eyes jiggling? Why are your eyes jiggling? So these are both pre-op, and you see when he looks to the right, there's a significant nystagmus, and when he looks to the left. And no other nystagmus procedure I've investigated has been able to flatline nystagmus inside gaze. And so for all of these procedures, when you get a good result, you have to be obligated to find out why. Not only because you want to be able to give that to all patients, but you also want to be able to define what patient it's going to be best for. And we're not there yet. And that's why so many of you are going, I had surgery, I didn't have surgery, I like it, worked for me, I don't know if I should. Well, you don't know yet. We can't tell you yet. We can only tell you we'll try our best and see what we get, but we can't tell you for your nystagmus, 50% this, 75% that, and that's where we need to be by the next meeting. Suffice it to say that if we just look at this arrow here in terms of reducing the amplitude of nystagmus, that is how high the excursion is, because when you change position over time, that's velocity. So if you reduce the excursion or the amplitude, you're also going to have a positive impact. And so with and without a fovea, we're able to reduce the amplitude on average 50 to 60%, in some patients up to 82%. And if we look at the frequency of the 10 patients in 1, 2, 3, maybe 4, we're able to 100% ablate the appearance of the nystagmus. Final on pursuit, this is a video of a patient who has nystagmus and is trying to track a target 10 degrees right, 10 degrees left, trying to simulate how someone would track across a page. And the second tracing, I'll let you decide for yourself, because clinically there's a suggestion that he's able to track better, although you see that in terms of pursuit, it's been tightened up from the pre-op. The green line is the target, the red line's right eye, blue line's left eye. So it's tightened up a little bit in the post-op. And so an important thing that we need to be able to look at, especially in terms of scanning the environment, finding something on a shelf, we have to be able to see not only the nystagmus straight ahead, but we have to see how it behaves across your field of looking. So we need new technology, and thanks to this meeting, I plan to collaborate with another eye movement specialist who's really an expert in calibrating these computer systems to measure eye position in side gazes as well as straight ahead. So hopefully we'll have more information on that. Now, in terms of negative effects, how often do patients need second surgery? 3 patients without prior strabismus required second surgery to assist in alignment of their eyes, okay? 2 patients without depth perception regained it after. Well, that means they probably developed it as a child, as they went into teen and adult years, they perhaps maybe crossed their eyes in an attempt to control the nystagmus, and that caused a reduction in their depth perception. Versions, we're just trying to show here that this is a patient pre-op, and this is now post-op. And I think what you'll see is even though the nystagmus was present in side gazes preoperatively, that postoperatively he's able to damp the nystagmus even in side gaze. So what are we going to do to improve the rotation of the eye? One of the problems we have is moving the eye toward the nose. So in patients who had, this patient had a very dramatic muscle removal over 4 years ago. She's trying to look to the left, and you see this eye is not moving in. And we've only recently come across an adaptation to our technique that now allows that eye to move in normally. So I'm hoping in our next round of patients to have them benefit from our ability to quantitate dynamic acuity and report on how that changes, and also to perhaps lower the incidence of any misalignment by improving the way their eyes turn in. So positive results, all 10 had an improvement in quality of life. All 10 had a subjective sense of nystagmus blur reduced 25 to 75%. In 9 of 10, the velocity and therefore the dynamic acuity improved. All had an increase in actual reading the chart vision from 16 to 37%. That's probably 1 to 2 lines. The reduction in nystagmus amplitude was 50 to 60% on average. In 7 of 10, the frequency reduced from 9 all the way up to 100%. And foveation times were dramatically improved, which I think we still need to keep track of, although its particular role in vision appreciation is yet to be defined, especially in patients with hypoplasia. Negative results in 3 of 10, we don't know why, but in 3 of 10, the frequency of the nystagmus increased 30 to 50% on distance fixation. So we need to understand why that happened in those patients and try to prevent that. 2 subjects reading computer felt that their computer vision was better on their questionnaire, but actually when you measured it was 1 line less on the test. So it wasn't functionally significant, but was recorded in our data. Convergence is pretty much all over the place in this 10, from a loss of 62 to a gain of 200. The speed of your eye movements, well, when you really reduce the speed of the bad movements, you reduce the speed of the good movements, but no more than 30%. So that's, I think, is acceptable. So I need to preserve now. I think I've stuck to my half hour. I've preserved the rest of the time for Dr. Yang. I'll be happy to take your questions at the end. I so much appreciate your support of ANN that allows us to be able to come and learn from you. So thank you very much. Are you connected already? Thank you very much. Thank you, Dr. John.
Sound in your presentation. Any sound in your presentation? Any sound?
No sound.
No.
Very good, very good.
All right, while they're setting up, I'll have to give Dr. Yang's introduction. So Dr. Dongsheng Yang is a pediatric ophthalmologist and president of the Shandong Purai Langkong Eye Hospital and director of the Purai Children's Eye Disease Ocular Motor Institute. The Purai Langkang Eye Hospital is one of 17 hospitals that belong to the Purai Eye Hospital Group. Formerly, Dr. Yang was a postdoctoral fellow working in the ocular motor disorders at the National Eye Institute at the National Institutes of Health. He also worked at the Ohio State University and the University of Pittsburgh. I worked many years with Dr. Richard Hurdle analyzing nystagmus eye movements. He now works as a pediatric ophthalmologist with a focus on nystagmus treatment. In China, he does about 500 nystagmus surgeries a year. So let's welcome Dr. Yang.
Thank you for the opportunity to commute. Thank you. Thank you for the opportunity to be here, to communicate with each other, to learn from other experts. Nystagmus. Yeah, for many reasons, we want to get rid of nystagmus. It is so impressive that the outcome from Dr. Lingua's procedure is encouraging. So I don't see a lot of procedures get this amount of reduction on the nystagmus. Luckily, my procedure also focuses on reducing nystagmus, not just correct the head posture. That's number one thing. Number two, I also emphasize the eye alignment after surgery. And in addition to that, we also value the post-op treatment. So not just slow down nystagmus, but also improve the visual acuity. So in order to have the accurate diagnosis, we use the eye movement recording to show the characteristics of the nystagmus. If you just use the naked eye, you won't be able to tell what type of nystagmus this guy has. So by doing the recording, this is from Lou Delosso, we have details to show here. We know which type of the nystagmus they are acquired, which type of they are infantile nystagmus. So we can use the waveform to make diagnose. So this is decreasing. This one is increasing. So you have different type of nystagmus, and also you may see the acquired the saccadic oscillation, and you don't do surgery on this type of the nystagmus. And by doing the recording, you got APAN or PAN. Why you do this? Because this could be clinically demonstrated, we call the double head posture or the double null position, because the head go with the direction of the nystagmus. Here you can see that the eye jerk to the left and then slow down and then jerk to the right. So the change is something that you need to know because your surgery related to this. This will help you to decide what kind of surgery you need to do. And also here, by doing the recording, you can see a convergence damping clearly. So if you see something like this, you may have have some idea, clear idea to do what type of surgery. Then after all that clinical useful information, you use your naked eye can see immediately, but you also need to use the software to analyze the data, quantitative the data, so quantify the data so that you know if the treatment is effective. So I am showing you the recording, how the recording is important. Here I already removed the horizontal eye movement traces, just leave the vertical movement here. The green lines for the right eye, the blue lines for the left eye. At this moment, as you can see, this is the right eye fixation. Then left eye becomes higher, and then you use your left eye fixate. Then the right eye becomes higher, and you use the binocular viewing. Now you see right eye and left eye that alternate. So this is a new feature we never observed if you use just the naked eye to watch the eye position. So what I'm trying to say is that when you have nystagmus and you have strabismus, it is very hard to tell if you just use a cover or alternate cover to see if there is a nystagmus, because the cover test evoked eye movement was covered by this all the time nystagmus eye movement. So you have to use the I'm recording to make a clear diagnosis, just like this. This person was a 15 years old boy, had the head posture. It's so hard, to decide to make a diagnosis that head posture is from nystagmus or is from strabismus. At the end, the test showed us it's from strabismus. It's a DVD. So we do the DVD procedure, then cure the abnormal head posture. So we now have some new surgical design. Let's say for this head turn, very regularly you may want to do Anderson-Kestenbaum surgery, but we learned, also we observed from our clinical patient. So for this type of surgery, the AP procedure, you don't get perfect outcome. So almost everybody gets improved, but the optimum outcome is not high. Let's say nearly 70% of the head posture come back a little bit. So the head posture come back, you're not satisfied. So what we do, and then we analyze the situation. We have a proposal. We have a theory that the surgery should focus on reducing nystagmus, not on head posture correction. But how? Then we think of the full muscle recession. For the horizontal nystagmus, we do middle and lateral rectus recession. But how many millimeter? There is a limit that says if you do more than 12 millimeter, the eye is going to get limited in the right-left movement. Is that true? And at that moment, we read Dr. Lingua's paper. And so we did a test observation also. Want to show you some results. This is to show that even you cut off the middle rectus and the lateral rectus, the eye still be able to move. That's really surprised us. So that on one side, that tells us that if you do a larger recession, the eye will still be able to move. On the other side, it tells us probably you won't be able to eliminate the nystagmus completely. So with that in mind, then also that there are some other factors you have to consider, like the dosage of the recession, where the new insertion should be, and the relation between these two, and the balance between the middle and the lateral muscles. You don't do the same amount of the recession, and then you have to consider how much the muscle can contract. Then we do use the adjustable suture in case that post-operatively the patient had any misalignment. But we still see strabismus comes. What happened? And in one patient, I still remember that 9-year-old boy and came back 5 months after the first surgery and with extropia. Then we had to correct the extropia. So during the surgery, we noticed that the lateral rectus is 6 millimeter ahead of the position we wanted the muscle to be. So I was surprised at the moment when we saw that. I thought, this is a new finding. Then the eye muscle can grow back to the original, toward the original insertion. What's a wonderful finding. Let's set up a program. Let's study this. And then a few days later, we thought that probably the muscle didn't go to the position we wanted the muscle to go. Why? And then we further analyze the situation. Then we realize that the muscle, 28, 27, 29 millimeter, they can contract only 10 millimeter. So if you recess more than 10, it won't go back that much. That's the problem. That's why we have to do a new procedure, which first you have to resect some millimeter and then recess. So you can keep the muscle in appropriate tense. They can go, pretty much where you want the muscle to attach to the global. So then we start to do the full muscle recession plus a resection. So with that procedure, I can show you this is the same guy, and a lot of nystagmus. This is post-op. So it's hard to say any nystagmus at all in the center viewing. But also I try to demonstrate that his eyes still be able to move to the sides, right, left. So the center fixation showing a very good reduction in the nystagmus amplitude. Not just that, this young guy is a very aggressive boy, and after surgery, he also entered the dark room for 10 days. After the surgery, 4 days after surgery, 10 days dark room. So I will talk about the dark room effect. This guy got normal vision and entered the college he really wants. And so with the success, stable results from the recession and the resection. So we have different opinion about different surgery. For this one, for example, the chin down head posture, usually we will do a superior rectus recess and inferior oblique myectomy. But that did change the head posture. Head posture always very satisfied with that procedure, but nystagmus usually only reduced by 30 to 40%. I'm not satisfied, the parents not satisfied. So we changed the strategy. We do, instead of doing the chin down surgery, just to focus on the head posture, we reduce the nystagmus, doing the full muscle recess plus the resection. Then the nystagmus reduced a lot. Then the head, the kids doesn't need to have the chin down posture, can see better. So the head posture gone for most of the kids, but not for everyone. So for this fifth turn head posture, we do 2 muscle recession. So not recession, resection. It's 2 muscle recession if the face angle is larger than 40 prism diameter. I prefer the 2 muscle recession. A lot of time, we don't need to have a resection in this case. The 2 muscle recession, I think, is better than the AK procedure. It's because we leave more opportunity to do re-op. You only worked on the 2 muscles. If there anything happened, and you can do the other 2 muscles. And also, you want to do the least surgery on the kids. It has a smaller post-op effect, and the kids recovered much fast. Otherwise, if the head turn is not having the big angle, we do 4 muscle recession and resection. But with the asymmetrical recession, it's just recess, because the resect increase the tense of the muscle and increase the nystagmus. That's my understanding. And for this case, so what kind of a surgery we need to do, regularly? It's multiple planar head posture, showing the face turn to the left, and also a head tilt to the left. So routinely, we may want to do a surgery like a face turn first, or the tilt. If we do tilt, then we will work on the vertical muscles doing the horizontal transposition. It has to be two surgeries, 6 months separate. But using our new technique, we found that if we turn the head to the left, the nystagmus also almost gone. If we let the kid tilt the head to the left, the nystagmus also almost gone. Of course, there, some the head down also helps. So based on this observation, so we don't need to do a complicated surgery. We only did 2 muscle recession. Okay, perfect head posture and nystagmus. So with the nystagmus, strabismus, and anomalous head posture, we do combined surgery. It is important that you diagnose the reason of the head posture. These 2 kids have similar head posture, but this one is caused by extropia. Yeah, the right one is caused by extropia. So by looking at this way, he gains binocular vision. That's the reason why he has this head posture. So the surgery is working on the horizontal muscle. For that one, that's what's because of nystagmus. You have to work on the oblique and the vertical muscles. And for the last year, our patients are increasing, and I do nearly 500 cases each year. But compare, how many patients I have, in China, our job is still nearly invisible. But I am still getting encouraged by the outcome of the surgery. And if you look at the top and down there, the parents said our kids' nystagmus get almost cured. Also, this kid is almost 6 years old. The surgery was done when this kid was a little bit more than 1 year old. Now the kid has nearly normal visual acuity. And this is from a young lady who was 27, 28. And before surgery, the eye just moved all around. Now, after the surgery, the dad told me that you save her life, because at that time, 27 years old, very beautiful young lady cannot even find a boyfriend. So it's so hard for her. So afterward, it's hardly see obvious nystagmus. And okay, we have another case that is 25 years old. So you see nystagmus. I don't know, in the back you see that clearly, but I want to demonstrate here is that this is post-op. You don't really see any horizontal nystagmus at all. But I asked her to look to one side, and she will do that. No, that said, don't move the head. And okay, so move to this, look to the side, still see nystagmus, but look straight ahead, don't see nystagmus. This that was nearly 4 months, and this lady, 25 years old, when she and her mom come in, and the mom, a little bit later told us, she, want to crime and suicide all the time, because the low vision, 20/40, 20/50, not too bad, but they just cannot accept that. And the mom had to follow her all the time. Look at the mom, it's horrible that he doesn't even have time to wash the hair. The hair is long and just, it's desperate. And it's a bad situation. After surgery, and the nystagmus get, so quiet, but I still don't see any, smile on their face. So in their mind is that we don't get the visual acuity increased though. So I didn't expect that this young lady will go into the dark room. At that moment, we have the room available, but she did decide to go in there. And 10 days after the darkness, and we started training. So day 1, day 2, day 3. At that time, after 3 days, we let them go home. This young lady refused to go home. I want to try more. I want to try more. So on the 4th days and the 5th days after the darkness, the visual acuity jumped 4 lines, 5 lines, and getting to a normal level, 20/20. We were surprised, how this happened. Now I start to see a smile on their face. They really feel happy. They wrote a long letter and to us, and really, they said, we went to so many places. Nobody said, we can get help. We can, nothing, they can do. But here you see a clear example that visual acuity improved and nystagmus almost gone. So this is a very successful cases. That's about the dark exposure. So we have some primary data to show you. So at this moment, for the dark exposure, we had more than, I think, 80 patients came out. But we only analyzed the data for 60 patients. For these 60 patients, 34 of them had 2 or more than 2 line increase. 6 of them get the normal level, which is 20/20, 10% get normal level. And then 9 get a 1 line improvement, which is not significant. And another 9, less than 1 line improvement. And 8 get no improvement. So in this 60 patients, actually, there are 30 patients had retinal disorders. According to the ERG test, their response are low, and also some OCT results showing that the fovea is not well developed. So not just visual acuity, but also we also saw several patients with abnormal binocular vision. Then after the darkness, after surgery and then after the darkness, we see large range of fusion and very good stereopsis. The depth perception also regained. Another thing I want to mention is the youngest age of the subject is 4 years old. But that was a special situation because the daddy wanted to go into the dark room also. Daddy and the kids go in there together. The mom delivered the food every day. So that helps. So the oldest was 55. We didn't gain anything. But for most of them, they are young kids, but also there are some adults. 6 of them get normal level. And so we have 7 rooms. Each room can have 3 patients. So all of them booked up. People want to get in there, but they won't until the middle of the August. So that's the dark exposure. And also, we use some therapy. One of them I want to mention is I call the binocular balanced film. Actually, it's just the neutral density film. But I cover one eye, but not a real cover. I just suppress the better eye because I cannot use the regular cover, the eye patch. If you patch one eye, the other eye get more nystagmus. It's very hard to improve the vision. By using the so-called binocular balanced film, I have both eyes, binocular viewing. The nystagmus doesn't increase as much, so you can improve the visual acuity. I think that's all for today. Thank you very much. Thank you. If you have any questions.
We are running a little low on time, but we have a little bit of time for some questions. We're up against a break, so we have a few minutes for questions, and then we'll break early. So if anybody has some questions for either Dr. Linger or Dr. Yang, feel free to ask them. Go ahead.
Should I take? So at 20 months, actually, the tilt is a good thing. The tilt and turn means that there's some place that he can put his eyes and have a quieter image delivered to the brain. And that's really what we're concerned about at 2 years, is that the brain gets a clear image so it learns how to see. So it doesn't become amblyopic or lazy. So as long as when we're testing the child in the office, we see that in that position of looking, the vision is good, there's no urgency, in my opinion. If in that position there's still misalignment, then you do have to think about some earlier treatment because we want to try to preserve depth perception. And to do that, you'd like to have the eyes straight, if possible, prior to 2 years of age. So if in that head posture things are doing good, be patient, figure, in my opinion, figure kindergarten, by kindergarten, and they start interacting socially with other kids, maybe even in preschool at 4, by then you want to think about any head turn surgery. But if at any time it looks like the vision's going down or their physical development is being hampered, usually they'll go in and out of it, right? Most kids will just run around and then they'll do that when they want to watch the TV. So as long as everything's progressing fine, I don't like to give kids anesthesia too young. So I'm a little more on the side of waiting a little bit. As long as everything's okay up there, that could be good.
I agree with you that head posture preserves the visual acuity because that gives the kids the least nystagmus angle that you can see better than the visual development is not delayed. But I usually encourage that you can as long as you have a consistent diagnosis, you know which muscle you need to do to work on, then you do the surgery as early as possible. It's different opinion because you don't want to have a head posture showing the neck have deformed, and so that's my opinion that you can do it as early as 2-year-old.
Yeah, I think anesthesia risk at 2 is about the same as an adult. So we'll agree on 2. But we certainly also agree that the first step in any surgery is to try to reduce nystagmus amplitude and maybe concurrently manage any strabismus, because doing vertical muscle surgery for tilts and turns can really cause a lot of difficult secondary surgeries or secondary strabismus that are going to be more difficult to manage in the future. And I'm sure we've all seen patients who after chin down surgery, will come back with these big stairs. may not be necessary because, just like you showed, if you can give the person a null point in primary, and I think with better rotations than the Keston valve, but if you can give them a null point in primary, even if they're shaking inside gaze, you're now allowing the normal visual development that was happening here to happen here. Okay? So whether you, no matter when you do the surgery, the primary goal is null point in primary. And if you can do that by getting rid of the nystagmus and straight ahead, then they won't adopt the head posture anymore, so leave those vertical muscles alone. So I think first step, take care of the horizontal primary null point nystagmus.
All right, why don't we do one more question?
My question is for Dr. Yang about dark exposure. How did you discover that dark exposure could possibly improve visual acuity? And is this something that should only be done after a surgical procedure, or can it be done at a later time?
Yes, you can do it later time. We find the animal results. I mean, 5 years ago, I guess, the animal model, amblyopia. Okay, two groups. One go to the darkness, the other just normal experience. And 10 days after, they start some kind of treatment. Only takes 4 days, 3 to 4 days. The darkness group, getting the VEP response to normal level. The other group, it takes 3 to 4 months to get to normal level. So when I read that article, I get excited. I tried everything, want to start it on human field until last year at our meeting. And I hear people talking about it. One of them is Dr. Elizabeth Quillen from University of Maryland. She told us, they started a multiple center research using the darkness 10 days, okay, not 9 days, because these, their results on animals show that 7 days doesn't work. So we're not risking to do 9 days, we do 10 days. But on the adults, so the adult results show that there are some, visual improvement, and there's no serious side effect. That's all we learned. At that moment, she told us, they are, just started, very early age, won't be able to help us a lot, and but as long as you don't have a side effect, we started, the darkness treatment, back in China since last July. So the first group, they are really, really difficult group. We only focus on the amblyopia. So we did get excited results. And then they brought this result, come back to Dr. Quillen, and she got excited. And she said, my subject, they are all adults. So your subject, you have 10 years old, boys, girls. So much encouraged. And also we had a very special cases at that moment. 11 years old, patient with nystagmus with albinism and large angle esotropia, 75 prism diopter. The visual acuity and higher myopia, visual acuity is poor, less than 20/200. And after darkness, she gains binocular vision, even stereopsis. I didn't believe that. I never learned that the large angle esotropia can establish the binocular vision, but she did. And Dr. Quillen was really excited. This is something new. We never learned. So now we have so many patients, not just the amblyopia, but also patients with retina disorders. Also give us a very exciting results, but not all of them. Some of them, didn't work. Their visual condition is very poor, but they have a hope of, let us try to get in. It's like that. It's it's patient to spread the word.
But to your knowledge, this is the first human study. Is that
Right.
correct?
Yeah.
So this is really a whole new, exciting question. To what extent does dark exposure and
that's
So another good there's so question. many
We will
questions.
have to study that.
Okay.
We know that light may be damaging, so.
All right, we have a small token of our appreciation for our speakers. Thank you very much.